Thanks for joining us. My name is Reba Rice. I'm the CEO of NorthLakes Community Clinic. I'm here to host what will be a series of conversations around the current status of COVID-19, the treatment options available in northern Wisconsin, the upcoming COVID-19 vaccine, and some of the questions around its safety. There's a lot of information nationally about what's happening right now, and we recognize that information can be confusing and overwhelming. So we're hoping that with a couple of conversations from folks on the front line, we can get some clarity around what's really going on right here in northern Wisconsin right now. Today's focus is around current treatment options. I've invited 3 area physicians to share their perspectives. At this time, I'd like them to introduce themselves. Let's start with you, Dr. Dreyer.
I'm Dr. Dreyer. I'm a family medicine physician with NorthLakes Community Clinic. I work out of our clinics both in Iron River and Ashland. I also am the Chief Medical Officer for NorthLakes.
And Dr. White?
I'm Dr. John White. I'm the Director of Emergency Medical Services at Memorial Medical Center in Ashland, Wisconsin.
And Dr. Reitz?
I'm Ann Reitz, family medicine. I am a family medicine doctor at the Red Cliff Community Health Center and the medical director there.
To start, Dr. Dreyer, why don't you walk through what a patient should do if they're experiencing COVID-19 symptoms?
First priority should be getting testing. It is really important from a public health standpoint to know how many people in our communities have the disease, as well as to be able to notify contacts and close exposures so that we can minimize the spread of the disease in the community. So the first priority, I would say, is if people start to develop symptoms, is to get tested. There's lots of options out there for testing, including the National Guard wing testing through the counties. There's easy access through the Department of Health Services through the state has a nice access on their website about all local vaccine areas and what events are happening when. The other is the clinics have access to some testing and local hospitals as well. Many of the clinics have the option for e-visits to be able to get that order for the test. There really should be no reason not to get tested. And I think that's probably the most important thing I can ask people to do is if you develop any symptoms of COVID or concerned about it in any way, get tested.
Thank you. Dr. Reitz or Dr. White, anything you would add to that?
And I'd like to add, and please stay home. Please don't go to work. I think that mistake is so easy to make, especially because people initially may have very mild symptoms. And we are all painfully aware of how many times people have gone to work and they want to go to work. They are afraid of leaving their coworkers without their assistance. They are desperately in need of their paycheck. But the bottom line is please stay home and get the test. And then I do want to just mention on testing that none of these tests are perfect. And so if you have symptoms and you test negative and you should run it by your provider. There's the COVID nurse hotline at the hospital. You can talk to a nurse about your symptoms and consider retesting in a few days if you still have symptoms, because there are false negative tests. Most of the tests are accurate, but there are false negatives.
Great, thank you. So let's take it to the next step. If somebody does determine that they have COVID-19 and they are maybe symptomatic but relatively mild, so that they can stay home, they are not needing to go to the hospital. Dr. Reitz, can we start with you? What happens next? What are the treatment options for me if I have COVID but I don't need to be hospitalized?
Well, I can comment primarily on the outpatient treatment and not in particular the monoclonal antibodies. So perhaps Dr. Dreyer and Dr. White can address that. But what we recommend for our patients is really to maintain their hydration status, make sure they're taking plenty of fluids, and they can use antipyretics, either Tylenol or ibuprofen, to keep their fever down, which also helps keep their fluid balance healthy, to keep in touch with their either the public health nurse or the contact tracers who are who want to know if they have any cardinal or alarming or life-threatening symptoms, and that we encourage patients to call either the clinic or the hospital to talk to a nurse if they have any new chest pain, shortness of breath, if they're feeling weak or feeling too exhausted to do the things that they need to do, if their fevers are extremely high and won't come down. Any concerning symptoms, they need to let us know so that we can give them recommendations on what to do. And then please stick with the quarantine recommendations that as given to them by the public health system. It's extremely important. And then if they can't self-quarantine, if their home does not allow that, in Bayfield and Ashland County, we've come up with ways for people to stay in lodging safely, and so that they can isolate from their vulnerable family members if it's not possible to do that in their home, because they really should have their own bathroom, if at all possible, and their own room.
Great. Anything to add about treatment options for mildly symptomatic folks, Dr. Dreyer?
Sure. As Dr. Wrights alluded to, our communities do have access to some newer medicines, which again are under emergency use authorization. They are what's called monoclonal antibodies. They are currently being used on patients with mild to moderate symptoms. And what this means is that you have symptoms of COVID, but you're not having increasing shortness of breath or low oxygen saturations. And so you can still safely be managed at home. And those patients, if you are within the first 10 days of symptoms and have other risk factors for having worse outcomes with the disease, such as elderly over the age of 65, diabetes, chronic kidney disease, you might be eligible to receive one of these monoclonal antibodies as an infusion. Currently, those are being done at the local hospital. You would work with your primary care provider to go through the consent and the understanding process of what these medicines are about. Then it goes to the hospital, who works through how available this medicine is and tries to get patients set up with the infusion. Typically, they're about an hour long and then do require a wait time afterwards or an observation period afterwards. So that is another option that we have. And the goal with that medicine is to potentially prevent the progression to more severe disease in this population group of folks who are more vulnerable.
Great. So what if folks end up getting really sick? Dr. White, should they show up at the emergency room?
Yeah, I think that's obviously the next step. And sometimes I think it's very hard for people to know when to go. But Dr. Wrights did mention, the symptoms to become most concerned about, increasing shortness of breath. I think most of the folks that we get coming through tend to be elderly, and they will tend to have somewhat different symptoms, such as generalized weakness, sometimes even just confusion, which may or may not be related to fever, poor hydration capabilities, and just generalized weakness. The idea again is to keep people in separate areas. So typically people will be put into our respiratory or zone 2, and the most important thing, at least from the initial assessment, is their vital signs. What is their oxygen level like? What's their blood pressure? What's their pulse? What's their hydration status? And so we end up doing basic blood work and a chest x-ray, sometimes a CAT scan of the chest. There's nothing really extremely complex about evaluating somebody with these symptoms. And then we put all the data together and kind of figure out, are they in need of hospitalization, or can we send them home with close follow-up? And if they are hospitalized, we we do have, a decent number of folks that have been hospitalized here in Ashland, and we have access to the medications that are recommended for patients with COVID that are in the hospital. And so people do have access to remdesivir and steroids locally, as well as the high flow oxygen and ventilators if needed.
So then if they are admitted, Dr. White, what does happen then? You said they have access to those treatments, but what does it look like from your deciding in the emergency department if they should be moved in onto the floor? What happens then?
Well, typically we have again an area on our medical floor which is sort of partitioned off so that we minimize spread amongst folks that don't have COVID, and then typically, again, depending on what their situation is, they'll receive steroids and remdesivir as well as oxygen therapy, IV fluids. Again, depends on what else might or might not be going on, what they may receive. But treatment tends to be primarily supportive. Therapeutics are available, but they are of limited efficacy and benefit in the big picture of things. It tends to be mostly supportive care.
And Dr. Dreyer, you are our hospitalist. You attend those patients in the hospital. Tell us a little bit about your experience with patients who are in the hospital with COVID.
I think the most interesting thing is we somewhat have a hard time predicting on how people will do. So some folks who I thought would struggle a little bit more with this disease have been in and out of the hospital in 5 days, and others who I would have otherwise predicted maybe a short hospital stay sometimes are there for longer. And it's a little bit more challenging and difficult to predict. It acts differently than many of the other infectious diseases that we have treated for many, many years. As Dr. White alluded to, the big thing for us is the supportive cares. Providing oxygen is probably the most important thing that we do. Then we have access to other medicines like the remdesivir and dexamethasone that can also help with the disease process. The other great thing I have to give a big shout out and kudos to our local referral hospitals, such in areas like Duluth. The specialists there have been super helpful to our medical staff, always taking questions from us, giving us some really good advice and answers so that we can provide good quality care to our local community at our local hospital, so that when we do send patients out to these tertiary care hospitals, like they really do get or really do need that high level specialty care. But the specialists at these hospitals have been really helpful to us as a group, and the medical staff has really come together to define some good protocols based on best data that's available, and actually utilizing data from all over the United States at different hospitals. So it's been really interesting to see just how the medical community, I would say nationwide, has really come together to help support each other with best practices. I think the hard thing for families is these patients are in these rooms kind of by themselves. The doors are closed. They have a separate ventilation system. And as Dr. White alluded to, we do have strict visitation policies. And so it is hard, I think, for families because they don't have as much connection to their loved one when they're in the hospital. We do try to really help out with having daily conversations with families, as well as providing access to things like iPads where they can, or phones so that they can connect with their families and be able to see what's going on. I think the great thing about having things like FaceTime and Zoom is that it's not as good as seeing somebody face to face, but being able to look at your loved one's face, even if it is over a screen, is just reassuring and feels good.
Right. Yeah, you mentioned that separation from our loved ones in this time, and it really can be very scary, especially because we are separated. Do you, each one of you, do you have recommendations on what patients or their loved ones can do to advocate for the best care possible during this time? And Dr. Reitz, maybe we could start with you.
Yeah, I think that that the the challenge is that they are physically separated from them, and encouraging them to maintain contact with the nursing staff and the provider staff that is taking care of their loved one is essential. And that can be difficult just because of how hard it is to reach people by phone, et cetera. And so it's a heartbreaking situation for them to not be able to actually be in the room with them. And it's hard to advocate for them from afar. And that's probably been the most frustrating and heartbreaking part of this disease for the families who I deal with who have had loved ones in the hospitals with COVID. But the more they can keep their communication pathways open with the nurses and the providers, the better. And the providers have done a wonderful job of keeping in contact with these families. Thank you.
Great. Dr. White, how about you? What recommendations do you have for advocacy?
I think it allows us, again, an opportunity for individuals and families to talk about what kind of care they want, at least in the immediate sense, but also long term, because as everybody has become aware, this is a disease which is causing a lot of deaths. And so I think as being an advocate for yourself in terms of what kind of care do you want, should you need to be intubated, or should that need come, you need to communicate with your family, and vice versa. The family needs to ask, Mom, what do you want? And then be able to advocate with your provider, this is what she really wants, instead of none of us knowing, and then we may do something that someone may not want us to do.
Great, thank you. And Dr. Dreyer, how about you?
I agree both with what Dr. White and Dr. Wright said. I think right now is a great opportunity to have conversations with families about kind of end of life wishes or planning and long-term planning. It doesn't mean that this illness is going to have an adverse outcome, but I think it's just an opportunity to talk about values and goals as we all face like serious illness or potentially traumatic events where we're not able to make our medical decisions. And one of the things I really see families struggle with is having loved ones feeling like they're making a decision for someone who is hospitalized, and then potentially having any kind of guilt about that decision. I firmly believe having conversations with your family early about what you would like, if anything does happen, is actually very freeing in a way, because that family member is no longer making that decision or feeling like they're making that decision for you. They are just voicing a decision that you have already made, and that I cannot emphasize the value in that.
Wonderful. Well, I want to thank you all so much for your time today to help educate our community and share your insights with our community. I also want to thank you very much for the work that you are doing every day to keep us safe and healthy. We know that this has been a really challenging time to be a physician, and we just are grateful. You are our heroes, and we're so grateful to you for all that you do.